Hello everyone. In this session, we are going to discuss about a very commonly asked question in your prof exam as well as for your PG entrance exam, that is graft rejection and graft versus host disease. They will give you a clinical case scenario of a 16-year-old man who has undergone kidney transplant. After that, some 7 to 8 days after or 1 week later, the patient presents with lot of complaints like fever, palpitations, tachycardia, oliguria, and symptoms of kidney failure. Already the patient has undergone kidney transplant, but still after that, after a period of 7 days, that too, the patient has developed these conditions or these symptoms, So what will be your probable diagnosis? Explain the etiopathogenesis behind it. Explain in brief about the morphological changes in the organ as a result of this. So these will be the possible questions you will get in your prof exam. Remember, transplant rejection, it is because of an immunological response. Because the transplant, it is the foreign body for our immune system. So the immune system will start attacking this. So that is actually the basic, very simple mechanism behind the graft rejection. So, what is rejection? There is a definition for this. It is a process in which the T lymphocytes and antibodies are produced against the graft antigen and finally destroy the tissue graft. There are some terminologies here. One is called allograft. Allograft means graft between individuals of same species. And if it is of different species, we call xenograft. For example, xenograft has been tried. Pig heart transplanted in humans, and it has been now told that the patient actually has died few days ago. So pig heart transplant, that is xenograft, but what we are following is allograft. So who are the person or who are the main mediators of this graft rejection? Of course, our usual T and B lymphocytes. Fine? Yes. So the major antigenic differences between a donor and a recipient, which is responsible or because of which the rejection happens, is the reason behind it is the difference in the HLA alleles. I told that these HLA genes are highly polymorphic genes, except in case of identical twins. But even they are telling, even in identical twins, there will be some very small differences. So, following transplantation, the recipient, for example, I am getting a kidney from another person. Fine. So, my T cell will recognize the donor's antigen from the graft by two pathways. One is what we call it as the direct pathway, and another one is called as the indirect pathway. What do you mean by direct pathway? When the graft's antigens are presented directly to the recipient T cells by antigen presenting cells, and further it will be processed. That is what we call it as direct pathway. Or sometimes it will be taken directly without any APCs. It will be taken directly by the cytotoxic CD8 T lymphocyte. Fine. And that will cause tissue destruction. That is called as indirect pathway. But whatever it may be, fine. Whatever it may be, both will finally leads to the graft destruction. So direct pathway and indirect pathways. Am I right? Both will leads to finally activation of CD8 T lymphocyte. But remember the indirect pathway. The indirect pathway means via APCs, such complex MHCs, everything. Yes, MHC, that is very important. MHC plays a very important role in case of the indirect pathway. What it is told that the direct pathway will be important for acute rejection. Indirect pathway will play a major role in chronic rejection. These 2 points only you have to finally remember. And remember, there are two pathways. One is direct and another one is indirect. Fine. I hope this is clear for you. Once this is done, then we will see what are the patterns or mechanisms of graft rejection. This will be the sub question. What are the different types of graft rejection? We have hyperacute, acute, and chronic. This is based on some clinical as well as the pathological features. What do you mean by hyperacute? Hyperacute rejection means already there are some preformed antibodies which are specific for the antigens on the graft endothelial cells. whenever there is a preformed antibodies, it's like almost like our sensitive reaction. Already there are some preformed antibodies. Okay, yes. And remember, these preformed antibodies may be IgM antibodies, which are specific for some blood group antigens. Okay, which are already been produced or induced by some prior exposure through some blood transfusion or pregnancy or some transplantation of another organ. For example, I got kidney from another patient. Fine. First transplant, no problem. One kidney I transplanted, no problem. So already I have some antibodies produced against that donor's graft antigen. Okay. After some 3 years, I am undergoing another kidney transplant. Now I developed graft rejection. So why the problem? Already from the same patient or from the same type of similar antigens, my preformed antibodies are formed now in my body. Now again, what? I am getting a transplant. So what will happen? This will trigger. Okay, and remember, these antibodies are mainly targeted against the vascular endothelium. Okay, vascular endothelium, and finally this will activate complement system, causing endothelial injury, thrombosis, ischemic necrosis of the graft. Okay, yes. And remember this hyperacute rejection, it is very rare. Because I told you, mainly here the antibodies are produced against the blood group antigen. This is the reason why for everything, even for a small surgery, we are doing what? Am I right? What is a blood group? Matching and typing. So there won't be any hyperacute rejection. Hyperacute rejection is very, very rare because we are always carrying on what we call it as cross matching. Cross matching is done to avoid whether there is any incompatibility between the donor and the recipient. We are checking it. So hyperacute rejection is very, very rare. Okay, yes. See, you can see here in hyperacute rejection, there will be some deposition on antibodies on the endothelium, which will cause complement activation, endothelial damage. Okay, and finally, so in this this picture, they will ask this picture. So what you are seeing in this picture, you can see some reddish deposit within the kidney. This is actually size of kidney. Okay, what is this? Nothing else but this is the glomerulus of the kidney. This is nothing else but platelet-rich thrombus. Okay, this is nothing else but the platelet-rich thrombus. So this is hyperacute rejection. Okay, hyperacute rejection. Once again, let us go through the morphology. Morphology is very, very important. Remember, kidney only mainly undergoes rejection. Okay, yes. The affected kidney which undergo rapidly cyanotic, mottled, and anuric. Anuric means it won't be able to produce the urine. Okay, there will be fibrinoid necrosis. Whenever there is an antigen antibody complex deposition in the blood vessel wall, what is the type of necrosis? Definitely it is fibrinoid necrosis. Then there will be accumulation of neutrophils within the arterioles, glomerulus, and peritubular capillaries. Okay, yes. And finally, what? The kidney may undergo infarction. Okay, and finally, it will be non-functional. It has to be removed. Okay, fine. This is hyperacute rejection. Let us see acute rejection. Acute rejection means it is mainly mediated by T cells, okay, as well as antibodies. That means here we have two types. Acute rejection, which is of cellular type, and acute rejection, which is of antibody mediated. That means simple. In acute rejection, we have one type, that is cell mediated type, and another type, that is antibody type. In cell mediated type, there will be activation of CD8 plus cytotoxic T lymphocytes, which will damage the graft, by vascular damage. The same mechanism, everything same. Complement damage, endothelial injury, thrombus formation, ischemic necrosis, infarction, finally death. Okay, the same principle. Whereas in antibody mediated, what will happen? Antibody mediated, there will be mainly classical pathway of complement will be activated. So this will be a potential MCQ question. Okay, in cytotoxic T lymphocyte, it will directly cause the damage. That is perforins, granzymes, and all. Whereas in antibody mediated, the classical pathway of the complement will be activated. That is responsible for endothelial damage and graft failure. Okay, yes. Now let us see the morphology. Morphology is the most important thing you have to focus in pathology. Rest everything you will study still more detail in immunology. So in acute T cell mediated rejection, there are some different types of patterns are there. This is I am taking about cell mediated type of acute rejection. One is called tubulo-interstitial pattern. Okay, also called as type 1, in which tubulo-interstitial, that means there will be involvement of both the tubular component as well as the interstitial. There will be excessive interstitial inflammation and the tubular inflammation. Okay, and this inflammatory infiltrates are mainly composed of CD4 plus and CD8 plus T lymphocyte. This is type 1 or the pattern 1, tubulo-interstitial pattern. The type 2 is what we call it as the vascular pattern. Type 2 is called as the vascular pattern. So vascular pattern, as the name it indicates, so it is going to mainly affect what? The vessels. So what will happen? There will be endothelitis or intimal arthritis. That means the tunica intima, which is of the blood vessel, which will be affected, which will be swollen. There will be lymphocytes aggregation, all those, and finally this will happen the leading to graft failure. So that is the important. Just know the keywords, because in exams or what we want to know at the end of this is just the keywords. Okay, we should not remember what is the mechanism in depth. Okay, we should know what are the key words you have to remember, because we have a lot to read, so we have to just remember the keywords. Okay. Then next, let us see what will be the morphology of acute antibody-mediated rejection. Remember the antibody-mediated rejection. How I used to remember? Remember, children, antibody-antigen complex will be deposited in the basement membrane. In the kidney, where is the basement membrane very predominantly present? In the glomerulus. So remember, the antibody-mediated rejection will be mainly manifested in two areas. One is in the very small blood vessel, another one is in the glomerulus. So there will be what? Inflammation of the glomerulus and peritubular capillaries. There will be complement deposition. Am I right? Yes. In depth of this, what are different types of complements we have in different types of kidney condition, nephritic syndrome, nephrotic syndrome. So I have told you that the classical pathway of the complement is activated. As a result of this, antigen antibody deposition occurs in the glomerular basement membrane. Okay. Now let us see what is chronic rejection. That means when this all happens. Okay, so this is the actually acute cellular rejection. Okay, let us see the etiopathogenesis: CD4 plus CD8 plus T cells. Finally, activations of neutrophil macrophages. There will be two patterns. Am I right? Tubulo-interstitial pattern, vascular pattern, and actually the picture B. Okay, this picture actually shows. You can see this bluish color. You can see this bluish color. That is lymphocytic infiltrate. Lymphocytic infiltrate. Okay, yes, and what you are seeing here, this is the tubulo-interstitial type. I am writing here. This is tubulo-interstitial type. Tubulo-interstitial type. That is type 1. This is type 2. What is type 2? Type 2 is nothing else but the vascular pattern. Type 2 is nothing else but the vascular pattern. Am I right? This is the vascular pattern. Okay, vascular pattern. You can see what you are observing here. Okay, I am drawing within. Okay, I am drawing a boundary. What you are seeing here, this is nothing else but endothelitis or tunica intima arthritis. Inflammation, simply inflammation of the vessel 1. Okay. Suppose in chronic rejection, what will happen? Chronic rejection, remember, in chronic rejection, there won't be such such active inflammation, but there will be graft arteriosclerosis. There will be interstitial fibrosis and narrowing of the blood vessel. That means the renal blood vessels will undergo thickening. The walls of the blood vessels will undergo what? Sclerosis and thickening. That is what we call it as arteriolosclerosis. And we have interstitial fibrosis. Okay, this is because of activation of what? Fibroblast, vascular smooth muscle cell proliferation. All these are most commonly what? Responsible for the chronic rejection. Remember 4 points. Because of the activation of fibroblast, number 1. Because of the vascular smooth muscle cell proliferation, number 2. What is happening? The third thing, interstitial fibrosis. And finally, number 4, graft arteriosclerosis. Just remember 4 points. Then chronic rejection. I told you the major important thing is intimal thickening, vascular occlusion. Okay, yes, interstitial fibrosis, tubular atrophy. Okay, then loss of renal parenchyma. And remember this inflammatory cell infiltrate will be very rarely found, because it is very chronic. After months or years only the patient is having in chronic rejection. After months or years only the problem starts. Okay, yes, remember the 4 points: vascular occlusion, intimal thickening, interstitial fibrosis, tubular atrophy, loss of renal parenchyma. Okay, here also remember number 1. Number 2, vascular occlusion. Number 3, interstitial fibrosis. Number 4, loss of renal parenchyma. Number 5, tubular atrophy. These are the 4 keywords you have to write. Okay, yes. Okay. How to increase the graft survival? That means in simple words, how to prevent this graft rejection? We can use immunosuppressive therapy. Okay, yes. Remember, HLA matching is mainly done for kidney transplant. Kidney transplant, we will do HLA matching. And what are matched? HLA-A, HLA-B and HLA-DR. These are the 3 things which we match. Remember, For liver, heart and lungs, because of some reasons like their anatomical compatibility, usually what we won't do what we call it as HLA matching. HLA matching is usually not done this, whereas in case of kidney transplant, remember this, they will ask you, okay, what is that, what are the matching they are done in? HLA A, then next one is HLA B, and next one is HLA-DR. Okay, these three matching you have to done, especially for kidney. For other things, no need of doing HLA matching. Very, very important. What are the immunosuppressive drugs we are using? Number one, steroids, mycophenolate mofetil, okay, which will inhibit lymphocyte proliferation. You can read much more about this in immunomodulators in pharmacology. Tacrolimus, then cyclosporin, it will inhibit what we call as phosphatase calcineurin. Remember, this calcineurin is very important for the activation of a transcription factor called NFAT, that is nuclear factor activated T cells. Okay, nuclear factor of activated T cells, and it will stimulate the transcription of the cytokines genes. Okay, and that is responsible for the activations of interleukin 2. Okay, then another one important thing is what we can give intravenous immunoglobulins. Okay. Fine. So now let us see here in this acute antibody mediated humoral means what? Mainly the problem is in what? The walls of the blood vessel. I told you endotheliitis. Okay, so this is a graft rejection. You can see, okay, you can see a thickening. Okay, you can see a thickening of the vessel wall. You can closely observe in this picture. That is nothing else because of the antibody deposition. Okay, antibody deposition. And of course you can appreciate see the what nothing else but the inflammation. Okay, that is the capillaritis. Okay, and the blue cells, no, what we are seeing is inflammatory cells. What is this? I told you in antibody mediated graft rejection there will be complement deposit. This is an immunohistochemistry, IHC, which shows complement C4D deposits in peritubular capillaries. Okay, I hope that is clear. Fine. Then this is chronic rejection. In chronic smooth vessel proliferation, vessel occlusion. 2 points. What are the rest 2 points? Yes, very good. Tubular atrophy, interstitial fibrosis. Then arteriosclerosis. Fine. Yes, you can see in this picture. You can see well in this picture. Okay, see what you can see here. I am drawing 2 circles. See that between the 2 circles you can see, you know, okay, I am drawing an arrow. That is thickening. Okay, yes. Then here you can see mesangial matrix deposition. And you can carefully observe in this picture there is duplication of capillary basement membrane. All these are characteristic features. Fine. Yes, here also you can see tubular atrophy. Okay, tubular atrophy. Fine. See, this is the blue area. The blue area indicates fibrosis. I hope this is clear. Fine. Then, next most important topic, that is graft versus host disease. Remember, graft versus host disease is most commonly associated with hematopoietic stem cell transplantation. When this GvHD occurs? It occurs when immunologically competent cells are transported to some immunologically compromised recipients. So the transferred cells will attack the host tissue. Usually the host only will attack what? The graft. But here it is the graft which is going to attack the host, because the graft have some immunologically competent cell. So suppose if it is I am ready to transplant my kidney to a HIV patient. So my kidney have what? Immunologically competent cells. This is going to attack the host. Why attack the host? Because the host is immunocompromised. That is the reason. Fine. Most commonly associated with hematopoietic stem cell transplantation as well as liver transplantation. Okay, or transfusion of unirradiated blood. That is why in immunocompromised patients always irradiated blood will be irradiated to prevent graft versus host disease. Okay. Yes. Here we have 2 types. Acute and chronic. Remember, acute means it occurs within days to weeks. Okay, within days to weeks after the hematopoietic stem cell transplantation. And remember, the major organs which are going to involve in case of acute are epithelium of skin, liver and intestine. And involvement of skin will lead to desquamation and a generalized rash. There will be destruction of bile duct which give rise to jaundice, mucosal ulceration of the gut which results in bloody diarrhea. All these are points. Epithelium of the skin, liver, intestine. 3 organs we are going to discuss. What is the manifestation in skin? Generalized rashes. What happens in liver? Jaundice. Ulceration of the gut leads to bloody diarrhea. What is the reason behind it? The reason behind it is direct attack by cytotoxic T lymphocyte. Whereas chronic means after some period of time, fine. So there will be extensive cutaneous injury with the destruction of skin appendages and fibrosis of the dermis. That means it may almost resemble like a systemic sclerosis. And there it was an acute liver disease. Here it was a chronic liver disease. So there will be cholestatic jaundice. And there bloody diarrhea was there. Here what will happen? Esophageal stricture. What? Because fibrosis, cutaneous fibrosis, almost similar to systemic sclerosis or scleroderma. And what is the major? Okay. Culprit behind it, that is CD4 helper T lymphocytes and B lymphocytes. Okay, yes. Okay, in this picture you can very clearly appreciate this is the epithelium. Okay, this is the epithelium. You can see epithelial cell death and dermal infiltrates of mononuclear cells. What are these groups? These are dermal infiltrates. Dermal neutrophil infiltrates. And this is chronic. What you are seeing here, okay, this is the dermo-epidermal junction, and these are lymphocytes. Okay, and you can see here the epidermis thinning. Okay, atrophy. That is very good because chronic. Okay, in kidney also we have told, no, chronic rejection, atrophy. Yes, the same thing here. Okay, yes, and you can see here lot of collagen bundles. What does it indicate? Sclerosis. All these are features of chronic. I told you it mimics like systemic sclerosis. Yes, that is the reason. So okay, so these are the important point you have to remember. And another one most important MCQ question: which of the following microorganism is most commonly associated with infections in transplanted patient? For example, I have given kidney to another patient. So which organism will most commonly infect that patient? The answer is cytomegalovirus. The cytomegalovirus induced pneumonitis. No, that is one of the most fatal complication of a recipient who has received a graft. So cytomegalovirus is one of the most important organism to cause infection of the graft, as well as it will cause fatal pneumonitis. Okay, that is cytomegalovirus induced pneumonitis in that recipient, and as a result it has to be properly screened. Okay, fine. Yes, so that is cytomegalovirus induced pneumonitis. I think you will read about CMV in virology, microbiology. At that time you will, the most characteristic feature of cytomegalovirus is it is the only organism, the most notorious organism which will cause infection of the graft. Okay, I hope this is clear for you. Fine, thank you. So with this, today we have discussed about the different types of rejection. Okay, what are the morphology, what are the different types, what is acute and chronic GvHD, that may be asked as a short note question with the morphological changes. Remember, skin, liver, intestine. Okay, in acute as well as chronic GvHD, we have to write what all happens in this. You can put a table and you can write the points of similarities and differences. Fine. And remember the mechanism. In acute it is CD8, there it is CD4 plus and B lymphocyte. So I hope this session is very useful for you. This is a very important topic. Go through the keywords, that is the morphology, that is tubular interstitial pattern, vascular pattern, tubular atrophy. Okay, that keywords is very important in morphology. Please focus on the morphology of all these organs, that is especially kidney. I told you HLA-A, HLA-B and HLA-DR has to be screened before the kidney transplant, whereas for other organs, because of anatomical consideration, there is no need for HLA matching or HLA screening before transplant. So I hope this session has been very useful for you. Okay, and hope you have enjoyed this session. Thank you.